Welcome back to Mapping Healthcare on KDRT 95.7 FM in Davis, California, where a medic with a map explores healthcare around the world, highlights people who improve it, and shares what we can learn from them. This is your host, Dr. Sheikh. Today I want to start by introducing you to Jim. Jim lives in a beautiful, rugged corner of the Appalachian Mountains, where the view is spectacular. But the nearest hospital is nearly 2 hours away over rough terrain. Jim is dealing with diabetes, a heart condition, and lately some suspicious-looking skin spots. In a big city, he would have a team of 4 different specialists, but in his town, he has just one. His primary care doctor, Dr. Ahmed. In rural America, doctors like Ahmed are what we call everything doctors. Because specialists are often a 5-hour round trip away, Dr. Ahmed is the one who manages Jim's complex heart medications, performs his skin biopsies right there in the clinic, and provides the mental health support he needs to manage his chronic pain. But recently, Jim hit the Medicare donut hole, a gap in his prescription coverage that suddenly left him facing a $500 a month bill for insulin. Because he lives on a fixed income, he tries to do what many in his position feel forced to do. He starts skipping doses to make the vials last longer. But Dr. Ahmed doesn't just write Jim a prescription. He spends hours helping him apply for a patient assistance program to ensure he stays on his medications. This is the essence of person care. It's a deep social bond where the doctor isn't just a person in a white coat, but someone you might see in the produce aisle at the grocery store. But Jim's lifeline is fragile. Only 1% of new medical school graduates are choosing to practice in towns like his. If Dr. Ahmed were to leave or retire, the consequences for Jim would be catastrophic. Without a primary care home, Jim would likely end up in the emergency room for routine issues, which could cost him and his community nearly $1,400 more every single year. Jim's story reminds us that rural primary care isn't just a convenience. It's the foundation of the healthcare system for 46 million people in the United States, nearly 20% of our population, who call a rural area home. And while the scenery there might be rugged, so is the healthcare landscape. People in rural areas face higher risks of death from heart disease, cancer, and stroke compared to people in cities. And they're hit harder by substance use issues and suicide. Today we're going to talk about why these everything doctors are so essential and what we must do to keep Jim's anchor from drifting away. Between 2019 and 2024 alone, we saw a 45% decrease in independent medical practices in rural areas in the United States. Thousands of rural physicians moved from being self-employed to being employees of large hospital systems or corporations. On one hand, this can bring in resources like electronic health records. On the other hand, it can drive up costs and push services out of the local community to tertiary centers hours away. We've also seen a record number of hospital closures. 150 rural hospitals in the United States shut their doors between 2010 and 2025. When a hospital closes, the travel distance to an emergency department or a drug treatment center can increase by 7 to 8 times. But while hospitals were closing, rural health clinics and federally qualified health centers stepped up. These are now the backbones of rural care in the United States. In fact, 90% of rural counties have at least one of these. They aren't just clinics, they're safety nets that provide everything from dental and pharmacy services to behavioral health, often on a sliding fee scale for people who can't afford to pay. Our guest in today's episode of Mapping Healthcare is general practitioner Dr. John Brennan. I know John from our work together on the board of the International Society for Quality in Healthcare, and we talk about his experience providing primary care to people in County Kilkenny in Ireland where he lives and works. The views expressed on this show are mine and those of my guests. So John, welcome to Mapping Healthcare. It's so good to have you here today.
Hi, Alfat. It's wonderful to be with you.
So John, you and I have known each other for a while through our mutual work with ISQA, the International Society for Quality in Healthcare. We both are on the board of ISQA. And when you're not at these meetings with me, you work as a general practitioner in a rural practice in County Kilkenny in Ireland, and also on the faculty at Royal College of Physicians in Ireland, where you teach clinicians about improving healthcare quality. And for many rural communities in Ireland and in many other parts of the world, the general practitioner is the most consistent and trusted point of contact with the healthcare system. So tell us what your typical clinical workday as a practicing GP looks like.
Thank you, Ulfa. Yeah, as you said, I mean, my first role is as a clinician, as a general practitioner. I work in rural practice, as you said, with my wife, Marie. Together, we run a team of 7, and we look after about 2,500 people spread across an area of about 265 square kilometers in East Kilkenny. My typical workday starts at about 8:15 in the morning. I try to get in a little bit ahead of the rest of the team to catch up on test results and to have a scan as to what the rest of the day looks like clinically. I then usually try to meet the admin team and the nursing team as they arrive in for a quick huddle or a quick chat about the day ahead, and then start seeing patients then from about 9:30 in the morning. So I'll consult clinically face-to-face from 9:30 till about 12:30. Then I'll usually have 30 or 60 minutes of consultations by phone or by email, 30 minutes for lunch, another few minutes to kind of huddle and look ahead at the rest of the afternoon. Then another sort of 2 to 3 hours of consulting, taking us up to between 5:30 and 6 in the evening. Then some tidy up between 6 and 7, more kind of lab results, correspondence, last few phone calls, that sort of thing. And I try to finish then kind of between 7 and 7:30 in the evening.
Yeah, so that's a really busy day, and don't know how you have time to do some of the other things that we work on together. And, as part of your expertise in quality improvement and patient safety, you helped teach a session at a past ISQA conference with me on improving quality in primary care. And rural primary care practices, they tend to be deeply relational with long-standing clinician-patient relationships and strong informal links with community services, community pharmacists, and other organizations. And this continuity can be a major asset for patient safety, for trust, for patient-centered care. So what drew you to work in rural primary care, and how has that shaped your understanding of the unique strengths and challenges of rural communities?
Yeah, so I suppose I had a head start in ways. I grew up in a general practice household. Both of my parents are GPs, and similar to the way myself and my wife work now, they work together in a rural community. So I had firsthand experience, in growing up of, how general practice within a rural community kind of worked, and all of those benefits that come from that way of working for the effectiveness of care, for the efficiency of care, for the deep personal relationships that you build with people over time, and for that wonderful continuity that you have an opportunity to create, right? Through my general practice training, I was lucky. I rotated through a couple of different practices, both rural and urban, bigger practices and smaller practices. And I definitely found in that experience the care that I found to be most satisfying, and the care where I felt we could deliver the best for people in the most person-centered way was in a smaller practice with high continuity and good comprehensiveness in the care that we can provide. As you say, I think, long before the term integrated care came into fashion, I think general practitioners and family physicians have been integrating care for patients, since they started in a way, where certain specialties maybe are more interested in one particular illness or body part. GPs are constantly integrating all aspects of health and healthcare and integrating between multiple specialties and other people working to improve people's health. So yeah, I find it a very interesting and satisfying place to be clinically. As you say, it's not without its challenges, but there are also huge rewards.
You said your work spans across multiple areas, multiple specialties, and of course, multiple ages. I'm a primary care pediatrician myself and can recognize that, gaining expertise in that area and seeing a little kid in the same day that you see the entire family, as full spectrum healthcare here. So primary care in rural area is really the backbone of our healthcare system. But it does operate under distinctive pressures that are shaped by a place's unique geography, workforce shortages, and demographics. So, from your perspective, what are the most significant barriers rural patients face in accessing primary care in Ireland? And which of those do you think are really the most urgent to address?
Yeah, so I suppose for our patients, the biggest barriers I think are probably to accessing other health and social care professionals. So, I mean, we work very hard to try and maintain access to, care with a doctor, care with a practice nurse. When it comes to accessing things like physiotherapy or speech and language, occupational therapy, social work, these other healthcare professionals who add so much value to health and healthcare, we have long delays. And where that's particularly difficult, I suppose, and it relates to your area of practice, Olfat, is for children with additional needs, where they need extra input from these particular professionals. And unfortunately, at the moment, our system is really lacking in that regard.
Yeah, and so people with medical complexity, this gets to be an added challenge. And we spoke so far about the care of patients and their families. Let's talk a little bit now about the care of clinicians in these communities. These clinicians are a precious commodity here for sure. And workforce shortages are a persistent challenges in rural areas everywhere across the world. So these areas face persistent general practitioner recruitment and retention issues, specialist recruitment and retention issues. And some of these issues are driven by the intensity of this workload, right? On call demands, sometimes professional isolation, maybe fewer training pathways that are rooted in rural settings. And we also see many rural GPs managing large patient panels with high complexity, especially people with multiple medical issues, multiple social needs. So, in the area you work in and in Ireland, I know you're really familiar with the health system there. What approaches have been effective in attracting and retaining clinicians in these communities in Ireland?
So I would say, I mean, the most successful approach in Ireland to date has been how training is regionalized. So, we have very strong general practice training in Ireland that's very well structured, very well organized, and tends to produce general practitioners of a very high sort of standard. And that training is organized regionally. So it means that people have, 4 years, 3 or 4 years, depending on prior experience, of learning in a particular area, but also within a network of GPs and general practices. So through that 3 or 4 years, they don't just get kind of the clinical exposure and experience that they need, but they also get an opportunity to build some of the relationships that can stand them in good stead into the future, and an experience of rural life and all of the benefits that that can bring to family and that sort of thing. The workload and workload pressures are very real. And obviously, the workload is growing all of the time with aging populations and multi-morbidity and that sort of thing. Marie, my wife and I mean, we manage it by, making sure we protect some time to pursue other interests. So, as you've said, for me, whether it's teaching in quality improvement or patient safety or teaching at an undergraduate level or contributing to the wonderful work of ISQA, that's something that keeps me fresh. I don't know if I could practice the way other generations have practiced now, across a working week, because I think, that sort of the workload over longer periods of time is definitely a recipe for burnout. So, increasingly when I talk to colleagues, they're trying to do similar things, maintain other avenues of interest and other special interests to keep them fresh. Within our area as well, we are very much in the process of kind of reviving and rejuvenating our local faculty. So we've had a lot of older practitioners in the area retire or in the process of retiring, a newer generation of GPs coming in. And we're starting to identify, needs around how we create and maintain a thriving network amongst ourselves to mind one another and care for one another too.
And you spoke about innovative ways of training people, right? So that they train in rural communities and see the benefits of working in these communities. There are also care models that are changing now to make it a little bit easier to get through one's busy work week. And rural primary care is deeply embedded in communities, but it's under strain, as we discussed. You're balancing, clinical responsibilities with limited resources while trying to make sure you get people equitable access to care, you keep your practice resilient to any challenges that come along, like a pandemic, for example. So, what are some innovative models of care that you think have the biggest potential in a rural setting like the one you work in as we look at our clinical day and workflows for care?
Yeah, so I suppose one major kind of initiative at national level over the last number of years that we've been able to, implement in Ireland is around chronic disease management. So before that, I suppose some GPs were providing some care for conditions like, heart failure, COPD, asthma, and diabetes, but it wasn't necessarily, structured or organized or, resourced or funded, right? In recent years in Ireland, we've had the introduction of a model of chronic disease management, which allows us to, provide, structured, reliable bundles of care to our own patients over longer periods of time, which means that we can ensure greater continuity when it comes to management of chronic disease, but also allows us to look after all of the other bits that can come with getting older, maybe, or managing a chronic disease. So when we're looking after a patient with diabetes, for example, and we're trying to encourage them maybe to lose weight and to get more exercise, they can also talk to us about, the low mood maybe they're suffering with, which is making it more difficult for them to get out and get that exercise. Or they can talk to us about the sore knee, or osteoarthritis that they're developing that might be limiting them. And we can continue to maintain that kind of comprehensive view of health and care and that continuity, which we think offers people, better outcomes in the longer term and helps them to realize better health. So that is one very significant innovation in terms of how care is organised in Ireland. And the data at a national level really is quite staggering in terms of the benefits that it has already brought to some of the more measurable aspects of chronic disease care. So we're seeing, weight, for example, in patients on these programs drop, smoking cessation rates are improving, reductions in alcohol intake, increases in physical activity, as well as improving HbA1c numbers, better blood pressure control, all of these different benefits. And I think that is in a large part because of how this care is rooted in continuous relationships for people and integrated into, a wider or a broader view of health.
Yeah, so clearly individual clinicians and individual practices are doing a lot with, the integrated management of chronic conditions and care coordination, just like you described. But of course, they need to be supported by policy change and investment to scale this up. And in the US, having a mixed public-private funding model does shape our rural primary care system a lot. Some patients receive free care, others pay out of pocket. And in rural areas with older populations or those that might have lower income, practices often care for a higher proportion of publicly funded patients, which can affect the financial sustainability of practices. So, if you could recommend one policy change or an investment that would have the biggest positive impact on rural primary care in practices such as yours in Ireland, what would it be?
Yeah, I mean, I think, we need to continuously find ways to work towards equitable, access based on need. We're lucky in Ireland that every child under the age of 8 and every adult over the age of 70 has access to free primary care. Outside of that, if you're on the median income nationally or less, you have access to free primary care. But there are all sorts of other barriers in the system and lots of other challenges in terms of navigating healthcare in Ireland, as you suggest, between public and private care. I would say, in Ireland, we're at this really interesting kind of point in trying to kind of reorientate the main focus of care and care funding from secondary care settings to primary care settings, really trying to turn that around so we can work towards, preventive care more so for populations. And I do think that that's going to require a significant investment in the infrastructure of primary care, right? So In Ireland, again, rural practitioners really struggle with infrastructure, the basics of having, a warm, dry building in a rural area to consult out of. That can be a big challenge for recruiting and retaining primary care clinicians to rural areas. So, I think if our health system is really going to succeed in this transition, then it's some of the basics that are needed to provide, high quality primary care that need to be put in place to attract and retain the clinicians we need.
You're talking about the basic structure and making that conducive to attracting the talent you need to rural areas. And, to wrap up our conversation and talking about talent, you're a man of many talents. You completed your medical education at University College Dublin, where you were also a sports scholar. You played field hockey. So think back to that time. What's one lesson from hockey that you think can be applied to rural primary care?
Yeah, I suppose maybe it's a lesson that's universal to lots of team sports. And that's that you can't do it on your own, right? And as you said, one of the biggest challenges to continuing in a career in rural practice is the threat of isolation and being on your own. So in our toughest times, in our practice, the busiest days and the days when things don't go to plan or things don't go right, it really is our team, that keeps us going and that makes it tick. And I think that's probably the biggest lesson that I've taken from sport. It's finding ways to cultivate the best possible atmosphere within a team so that everyone can sustain one another when you're faced with those difficult days.
Yeah, for sure. Team-based care is where rural practice, really can excel. And, that team-based care, I think, in any underserved area, whether it be rural or urban, really elevates our work and also keeps it sustainable, right? In addition to the work, it's the working relationships with your team and those long-term relationships as well. So those are important lessons from sport that you drew to primary care in rural areas. And we close a little bit by talking about the place our guest comes from. So let's keep the sport theme for a few seconds. County Kilkenny, where you work, is famous for the sport of hurling. I remember traveling through rural Ireland a few years ago and a local pub owner giving my kids an impromptu hurling lesson in his backyard. So, what are the experiences should someone new to County Kilkenny check out?
Yeah, so in addition to some hurling of that, definitely, Kilkenny is quite famous for its medieval architecture. So, there's a beautiful Norman castle in Kilkenny and a medieval mile that you can walk with lots of different, places to explore from the last 700 or 800 years. So that's nice. Mixed in or interwoven with that is a thriving kind of art scene, visual arts and music in that as well. So I'd encourage anyone thinking about coming to visit Kilkenny to check those out as well.
Yeah, and that's a lovely blend of the historic with the new and the innovative, just like rural practice and general practitioners have been in Ireland for decades and centuries, right? So I thank you, John, for continuing on that rich tradition and providing excellent care. You and your wife both work in that practice, right? So providing a true family experience for the families you serve. And thanks for being on Mapping Healthcare.
Thank you so much, Alpha.
So that was Dr. John Brennan telling us about his experience as a primary care general practitioner in rural Ireland. People sometimes have a misconception that rural care is limited. But rural primary care is actually more comprehensive than urban care. Because there aren't a dozen specialists down the street, rural doctors have to be the everything doctors. They're more likely to perform skin procedures, manage complex chronic conditions, and provide emergency stabilization. One ICU doctor in Idaho put it perfectly. They want to train rural family residents because that's the person who's going to stabilize a patient 5 hours away in a snowstorm before they can be transferred. But here's the challenge. The everything doctors are running out. There are 15% fewer primary care clinicians in rural areas than in cities. Only 1% of new medical school graduates are choosing to practice in rural settings. This leads to massive patient panels and extreme burnout. And when a rural town loses just one primary care doctor, it's an economic catastrophe. That one loss can result in nearly $1.7 million in additional healthcare expenses for the community over a single year, because patients end up in expensive ERs for things their doctor could have handled. We've tried to fix this with technology, but we've hit the digital divide. While telehealth is a great equalizer, nearly 26 million Americans, mostly in rural areas, still lack reliable broadband. You can't do a video visit with your doctor if your internet can't even load a web page. Primary care, both in rural Ireland and in the rural United States, depend heavily on committed generalists working at the edge of capacity. And both health systems show that strengthening rural primary care is less about technology alone and more about workforce support. So if you're someone who cares about the health of our country, what are the big take-home messages? First, rural primary care is person care, not just health care. In a city, your doctor is someone you may see every 6 months or so. In rural Virginia, your doctor is the person you see in the produce aisle, at the grocery store, or at the Friday night football game. This creates a level of trust and social connection that you just can't measure using a lab test. We need to protect independent practices because those social ties are the secret sauce that keeps these communities healthy. Second, financial incentives are the best tool for recruitment. If we want doctors to move to Jimstown, we have to help with the money. State loan repayment programs and scholarships show the highest success rates for keeping doctors in rural areas long term. We need to fund these programs like the vital infrastructure they are. And finally, we need rural-friendly payment models. Right now, many insurance models, especially in the United States, are built for high-volume city clinics. They don't account for the Jim who has to deal with excessive healthcare costs, or driving hours to see a doctor, or the fact that a rural clinic might only see 10 patients a day instead of 40. We need to move toward hybrid payments, fixed monthly budgets that allow rural doctors to focus on whole person health, rather than just billing for every single prescription they write. Rural primary care is remarkably resilient, but it shouldn't have to be a struggle for survival. As one clinician in rural New Mexico said, "We love what we do what we love." It's time we showed that same love back to our rural communities. Thanks for tuning in. This was your host, Dr. Sheikh. You were listening to Mapping Healthcare on KDRT 95.7 FM. Connect with the show on Instagram at Mapping Healthcare to share your thoughts and ideas for future episodes. You can hear Mapping Healthcare around the world anytime on kdrt.org and wherever you get your podcasts.